All right. Hello, everyone. Thank you very much for joining us on this very cold winter evening in Melbourne today. Today, the Northwest Melbourne PHN is presenting on deferred care. This is the first of 3 sessions, and today my colleagues Natalie and Jeannie, Dr. Jeannie Knapp, they're presenting on deferred care session 1, immunisation, STIs in mental health in younger adults. And moving forward, I will, sorry, I can't seem to change my slides, just bear with me. Yes. I'd like to begin with the acknowledgement of countries. So I would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Wurrung people, the Boonwurrung Wurrung people, and the Wathaurong people. We pay respects to elders past, present, and emerging, as well as pay respect to any Aboriginal and Torres Strait Island people in this session with us today. So, just a couple of things about housekeeping. All attendees are muted. Given that it is a webinar, I would request that all questions please come through the Q&A box, and they will be answered at the end of the presentation. Just a couple of things to note, please. The session is being recorded. And when the questions come through Q&A, I will read them out to the presenters and they will be answered, and we will ensure that your identity is kept anonymous. When it comes to your name in the session, kindly ensure that please you join the session using the name that you registered with, so that we can mark your attendance for CPD purposes, and can allocate your points to you for CPD purposes if you're a GP, or send you your attendance certificate if you are attending with us tonight. If you're unsure of how to change your name, then here's a brief slide. You can click on the participants button at the top of the Zoom window up here. You simply hover your mouse over your name in the participants list on the right side of the Zoom window. You click on rename and then you enter the name you registered with. So this is just a quick little screenshot on how you do that. And that's that. I just wanted to introduce the speaker panel. So today with us, we have Natalie Simpson-Stewart and Dr. Jeannie Knapp. Natalie is an experienced practice nurse with 15 years of nursing experience in various settings, including defence, community settings, and primary care. You may have seen Natalie from previous sessions as well. She's a regular presenter for our PHN and has a passion for chronic disease management, utilising digital health tools. She's an absolute guru at Penn. She is also known to run successful immunisation clinics. So she is certainly a pocket rocket. Dr. Jeannie Knapp is an absolute amazing GP who moved from New Zealand to Melbourne in 2005. She's a practice owner in Richmond. Dr. Jeannie has a QI lead role in her practice, and in addition to all the wonderful things she does, she's also the clinical advisor to the Primary Healthcare Improvement Team at the Northwest Melbourne PHN, and I work in the Primary Healthcare Improvement Team as well. I work as the Workforce Development Program Officer in the Primary Healthcare Improvement Team at the Northwest Melbourne PHN, and I support everything that is workforce development, which also includes education and training as one of its main components. So we are very pleased to have all of you today and this wonderful speaker panel who will talk to you about deferred care. And I will pass on to the wonderful speaker panel from here onwards.
Okay, hello, welcome, good evening, everybody. Let me grab some slides and I'll start sharing my screen, and then we can get onto this wonderful topic of deferred care, or all the things we haven't done because it's not related to COVID. So let me just swap over here. We'll go to this one. We'll go away. Google. Always so wonderful. All right, there we are. Now, can we see some slides up for everyone?
Not as yet.
Not yet, that's all right.
I'm still seeing Sadia's last slide.
That's okay. Zoom's just having a small moment, but that's okay. That is Zoom's prerogative. All right, this should be slightly better, I think. Okay, how are we going?
Not as yet.
Why is Zoom share screen? Yes.
Do you need to stop sharing, Sadia?
No, Natalie's a co-host and can take over my screen
There we
anytime.
go. Here it is.
It's got there. That's right. Clearly my computer needs a coffee, as do we all. Okay, so part one of the Deferred Care series. So goal of today is really looking at our younger cohorts or our under 40s and really getting back in tune with things that we have been missing over the last few years. So Sadia's given us a lovely introduction. We won't reflect on how long I've been doing my job, and I'm sure Jeannie feels the same way. So reviewing the goals of the three presentations that we'll be doing. So identifying those key gaps of things that have been backroomed while we've been dealing with COVID, and giving you guys the tools to be able to identify those groups and that missing care within your own practice. The other big thing I wanted to do was really get on board with all the amazing things that the PHN have on offer and also other providers in our catchment area to help support us as we move into this, I don't like the word COVID normal, but COVID normal. As a sort of unofficial goal of the series, I also consider it the Marie Kondo post-COVID of trying to spark joy in what we actually signed up to do this job for, and hopefully give us all a bit of an enthusiasm for the passion that we have for our jobs. So today, or this evening's series, will be focusing on the under 40s. So three main topics. First is focusing on adult immunisation with a little bit of a touch on the adolescent program in the context of what's been happening during COVID. Section 2 will be moving on to sexually transmitted infections, which have been an issue pre-pandemic and certainly revving up post-pandemic. And Section 3, even though we're all sick of talking about COVID and its impact on mental health, we're going to talk about COVID and its impact on mental health. So as we launch into it, I'm going to hand over to Dr. Jeannie, who will refresh us on the impact of COVID on immunisation and why that's so important for our clients. Thank you, Jeannie.
Thank you, Natalie. If you could, oh, Sadia, I think you might need to mute because I'm getting feedback off you.
All right, certainly.
If you could flick to the next slide, please. So, interestingly, the impact of COVID on immunisations, the one thing that wasn't impacted, which I would have expected to have been impacted, was childhood immunisations. So childhood immunisations kept on going, and essentially that's because we do them in general practice, we kept on going, and we're amazing. The vaccines that dropped off were those in the school-based program. So kids weren't going to school, so they were missing out on their vaccinations. So we can see there that the tetanus boosters dropped, the meningococcal boosters vaccination program dropped off, and HPV, while overall rates continued to improve, timeliness of vaccination suffered, meaning that some people just might not have completed their course. And the graph at the bottom there shows lockdowns 1, 2, 3, 4 and 5, and you can see that change happening in those HPV vaccination rates. Next slide, please. And so why does this matter? Well, I guess we all work in primary care. We know how important vaccination is. And especially these adolescents are getting that waning of childhood immunisation. So they need their tetanus boosters, they need their meningococcal boosters. And this young adult period is a time of increasing risk-taking behaviour, which can increase the risk of transmission of some of those diseases, as well as, international travel. We might get to start travelling again. And we know that we need that 80% herd immunity for HPV vaccine to be successful in our goal to eliminate cervical cancer in Australia by 2035. Next slide, thank you. Measles. We know that, pre-COVID, measles was that highly infectious disease that we used to deal with. We've forgotten about measles because we've been so busy COVIDing that measles has gone off into the background. But interestingly, there was a new case reported in Victoria just this week. Measles is one of the leading causes of infant mortality and worldwide, and significant morbidity. Rates are increasing globally, and a lot of those outbreaks are in our geographical neighbours, especially countries frequently visited by Australians such as Samoa, Tonga, Fiji, New Zealand and Indonesia. Good old Bali is apparently a measles hotspot. Next slide, please. And why does this matter? Well, we need 2 doses of a measles-containing vaccine to provide sufficient immunity. And many of our patients born in Australia and many other countries, kind of prior to the kind of 1990s, may have only had 1 dose of vaccine. And in fact, yours truly had to have a measles booster just last week because I'd only had 1 dose, I discovered in my past. And of course, the measles vaccine also covers mumps and rubella, which are important additions for people considering pregnancy. Next slide. And then hepatitis B. Hepatitis B is the most prevalent bloodborne virus in Australia, despite a successful childhood immunisation program. Now, that's partly because anyone over 36 has not been captured by that program. What am I looking at here? This is the rate of hepatitis B going up and up and up. Next slide, please. And hepatitis B is the leading cause of liver cancer, which is the fastest increasing cancer in Australia. And so we mentioned that some older Australians wouldn't have had, or Victorians wouldn't have had hepatitis B. There's also lots of people born overseas. Remember that 40% of our local population were born overseas. Other priority populations that are within our PHN, Indigenous populations, and especially in the West. And those unvaccinated people are obviously at high risk of infection. So in addition, people living in households with hepatitis B, IV drug users, men who have sex with men, sex workers, people in custodial settings, and people living with Hep C and HIV. They're all other high risk groups. So there's a lot of high risk groups within our PHN and potentially lots of unvaccinated people living within our PHN. So I'm going to hand back to Natalie. I've hopefully defined the problem, and now Natalie's going to tell us what we need to do about it.
Thanks, Jeannie. So how do we move forward with all this knowledge of, oh, there's all these unvaccinated or under-vaccinated people running around? So key points: all people aged under 20 who are eligible for Medicare, whether or not they hold it or not, if they are eligible for it, they can access the government-funded vaccines under the NIP schedule free of charge. No cost to them, obviously. Consult fees not included in that. As long as that schedule is commenced before they turn 20, it doesn't matter if it's continuing after their 20th birthday, the entirety of their catch-up schedule will be government funded. So looking at people that may be above 20, so vulnerable citizens, so looking at our homeless or insecure housing, our humanitarian entrants, including refugees and asylum seekers, who they may or may not be eligible for Medicare. Within 2 years of their arrival in Australia, they are entitled to a government-funded catch-up schedule as well. Now, in terms of me talking about these catch-up schedules, if you have a nurse immuniser in your practice, it is covered as part of their training to do catch-up schedules across the lifespan. So certainly pass those patients on to your practice nurse and they'll be able to come up with a plan of how we're going to get these people immunised as quickly and safely as possible. If you don't have a nurse immuniser in your practice, Health Pathways have a really great resource on how you actually go about immunising someone who wants to know if they need updated immunisations. So you can jump on your Health Pathways, it's there. Not just adults, they actually have a couple of other really relevant immunisation pathways that you can look at, including pregnancy and services that are available in the catchment area where you can refer to as needed. So what if my patient is over 20 and they're not a humanitarian entrant? Well, they are probably going to have to pay for most of their vaccinations. However, there are some state-funded programs that may be eligible for them for at least some of their catch-up immunisations. So measles, mumps and rubella has been funded for women who are not immune to rubella, who are planning pregnancy or shortly after delivery. Remembering this is a live vaccine, it should not be administered during pregnancy, and women should be counselled to avoid pregnancy for 28 days after the vaccine. Now, it doesn't put a timeline on when that person is planning their pregnancy. They could be a 21-year-old uni student who's coming in for uni. They're a woman. I'm like, would you think you might have a pregnancy at some point? And they say yes, well, they're planning pregnancy. They can have that government vaccine. The relatively newer catch-all under this program is that for people that don't have documented evidence of 2 doses, they can have catch-up immunisations government funded, or if we've done serology and they're not immune to measles, mumps or rubella, they can also have a government catch-up schedule. You don't need to do serology prior to immunising. If their childhood immunisation record says they've only had 1, you just go ahead and do that second one. That's not a problem. Little practice point, just remembering that the measles, mumps, rubella, varicella combined vaccine, so that's pro, quad or your prior, etc., is not for use in people 14 and over. It's only for use in children. So another state-funded program, so looking at people that have a non-functioning or absent spleen, and that includes things like sickle cell disease and some other of the hemoglobinopathies, they are entitled to a catch-up schedule that covers them for meningococcal and Haemophilus influenzae B. There is also a medication that's used in the treatment of myasthenia gravis called Syphilis, which will affect complement proteins. And there are some disorders which affect complement components who are also eligible for this catch-up schedule. You can jump on the Spleen Australia website and they've got some really great resources on who needs which vaccine when. Now, hepatitis B. So this is funded for all people who are at increased risk who have not been previously immunised or we're unsure of their immunisation status. So all people who identify as Aboriginal and or Torres Strait Islanders who don't have a record of immunisation or when we've done serology or non-immune can have their entire course. Household contacts and sexual partners of people living with hepatitis B. So remembering people that were born in endemic countries, you may have parents or grandparents with chronic hepatitis B, and you've got people that were born in Australia, but they're still in that household if you're in a multi-generational household. Also remembering people that do sex work in this group, we don't know if their sexual partners have hepatitis B, we're better off to protect them. Men who have sex with men, people who inject drugs or on opioid substitution therapy, hepatitis C, HIV, we don't need to double down on liver disease for them. People who've left a custodial setting who did not receive or didn't complete their Hep B schedule. So generally speaking, serology is done on entry into prison facilities around Australia. If they're not immune, they will be commenced on an immunisation schedule, but obviously the completion of that schedule is dependent on the length of sentence. So if you are seeing people who have been in a custodial setting, just check with them, did they have all 3 of their hepatitis B, because we can finish that course off for you for free. So those endemic countries. So anyone that has arrived in the last 10 years from these countries is entitled to a full course of hepatitis B. So I've listed those there for you. Obviously, they're on the Victorian Immunisation Schedule PDF as well for you to refer to. Okay, so I like to call this presentations that go ding. So when these people are walking into your office, there should be a little bell going off in your head of, I should be asking about immunisation status for these people. So linking an immunisation review with those triggers. So obviously women coming in for, pregnant people and their partners coming in for antenatal screening, what's their measles, mumps, rubella status? Obviously we're checking with their serology. Let's flag, do we need to be doing this postnatally or before they get pregnant? If they're coming in for STI screening or a PrEP script, what's their bloodborne virus immunity status? When you're seeing new patients or updating patient information, remember to ask about country of birth. Now, one of the big letdowns of practice software is it will ask about ethnicity. You may have someone who identifies as being Australian, but they were born in another country. So it's really about that country of birth. That's going to guide that risk assessment. When we're seeing infants and small children for immunisations, let's ask about their parents' immunisation status. Where is their country of birth? Do we need to be looking at those people as well? If you'd like to do a bit of a deep dive because you've got some spare time on your hands, don't laugh, you can jump onto PenCat and actually pull up immunisation data from your practice software. I've covered this in a couple of other webinars previously. So if you jump on the PHN website, at the top in the menu bar, there's the section on events, news and resources. And in the resource library, you'll find YouTube videos of my lovely voice telling you all about PenCat. So that's the title of the 3 most recent ones that I've done that would guide you how to find that data through PenCat. The other useful thing we have in your PROTA accounts, in the immunisation register section, you have a report function. And what that can do is pull data on overdue vaccinations, and you can filter that however you like. So by provider, if you want to focus on a particular doctor, by the whole practice, which disease you want to focus on, or particular age groups. So I've done some screenshots just to give you a brief familiarity with what you're going to be looking for. So when you're logging in through PROTA, if you're a practice nurse, you're going to need to go into your delegation, then go into My Programs, and the Australian Immunisation Register will pop up. When you open it up, you'll see down on the left-hand side, there's a section where it says Reports. This is the first window you will open up to, and you can see there you can look for your AIR due overdue reports by those filters. Once you've usually picked, and I usually pick by practice, so I'm looking at the entirety of my patient cohort, you can then name it whatever you like, depending on what you're going to be looking for. You have an option to run that report. You can do as it a one-off. You can set it a certain interval if it's something you want to include in your QI PIPs. With the output, I always say do a single file that will give you a single Excel file of your data, which is much more practical. You'll need to put your PIP practice ID. So when it's looking for data from your clinic, it needs your practice ID to know who your clinic is. Where this comes into is the next section. So when you go looking for who you want to find, you can actually choose any patients you've seen at that clinic in a certain time frame. So for QI PIP reasons, I always filter it to 2 years. So any patient that we've seen in the last 2 years that has had an MBS item claimed through us will get picked up with this report. Obviously, with the immunisation status, we only want to know about the ones that are missing. If you ask for all your patients' immunisation status, you'll be there for 48 years. So the next, scrolling down, you can choose which disease you'd like to focus on. You don't have to choose something. You can go all diseases in this section. And then when it comes down to age selection, you can either go by birth date or by age, but you are limited to a certain amount of a time frame that you can look for. So if you're going by age, you can only do a 5-year gap. So in this example, when I'm looking for overdue details for human papillomavirus, I'm looking at people between 13 and 18 because that's really going to be catching them once they've moved past that immunisation point at the school-based program. So I'm going to be picking up people that haven't completed that course, not ones that haven't been got to yet. There's another couple of options down the bottom if you want to further refine your results. So once you've done that and you submit your request for a report, it won't happen straight away like Pantene, it will happen. When it comes through, you'll get an email link that is the email link to your PROTA account telling you that your report is ready. Log back in, come back into the report section, and you'll see a section where we had request. Up the top it says view, and that's where your new report will live. You can then download that report and you will get a much more identifiable report than this, but this is my overdue report. So it tells the patient's first name, last name, their gender, what disease that or what vaccines they're overdue for and when that vaccine was due. So it's a really easy way to recall those patients. Particularly, and I tend to do a monthly report on my patients that are about to turn 20 to really catch them and say, look, your last opportunity for your government funded vaccines is coming to an end. So hustle if you want to get vaccinated. Okay. So in terms of resources, immunisation handbook, your Bible to who gives what, when, and which vaccine. In looking more towards patient resources, the Australian Academy of Science has a really fantastic section explaining how vaccines are made and how a vaccine works. Really pictorial. They've got some really good stuff for kids as well. So fantastic. I have it in a hard copy, which can be a little bit difficult to get a hold of now, but the website is wonderful. National Centre for Immunisation Research and Surveillance. They have some really great in-depth fact sheets. So if you have patients that are wanting a little bit more information than the basics, that's usually my go-to referral. They also oversee the SmartVax program and collate all that data about adverse event reporting. So if patients want to know what's happening post-immunisations in terms of adverse effects, that website has all that information too. Melbourne Vaccine Education Centre, really good, basic, well-researched information, a really good entry point for parents who have questions about vaccinations. They also run fantastic education sessions throughout the year. A little less, a little more disappointing on webinar. It was much nicer getting to go in person, and hopefully one day we will have that again, but certainly their education library is wonderful and covers a wide range of topics. So I'm going to hand back to Jeannie now, moving on from vaccinating against diseases to let's go look for them. Jeannie. Thank you.
Thanks for that. I didn't know about that AIR stuff. That report is just amazing that they can pull that data, and a really useful report to know about. If you could pop onto the next slide for me. So the impact of COVID-19 on STIs. Now, it came as a shock to me to discover that not everyone followed the rules during lockdown. And certainly post-lockdown, people are doing some serious catching up on the rules that they were only minorly breaking during lockdown. So while there was possibly a decrease in sexual activity during lockdown, there was certainly a resumed activity between times. But there was certainly a huge decrease in presentations to sexual health services. And those sexual health services were delivered in different ways. There was the move to telehealth like we all have, but also across a number of the services, full suspension of services for asymptomatic heterosexual individuals, and a move to self-collection for oropharyngeal swabs. PrEP usage dropped during lockdown, and possibly as many as a quarter of men stopped taking their PrEP during lockdown. And while there was a reduced presentation of the mildly symptomatic infections, there was no change in the number of presentations for notable symptoms such as PID or primary syphilis. Thank you. Next slide. So why does that matter? I guess the key thing is that untreated or late presentation and treated STIs increase the risk of complications such as infertility, and on the background of this, the rates of most STIs are rapidly increasing, with significant outbreaks in the wild western suburbs. And there's increasing presentations in heterosexual women. And of note, particularly syphilis is increasing in heterosexual women, which has significant implications for things like congenital syphilis. And while new HIV diagnoses are in decline, the diagnosis in late stage is increasing. And obviously, like any condition, the later we get it, the harder it is to treat. So there's our gonorrhea numbers. And this is pre-pandemic. So pre-pandemic, numbers were already, well and truly on their way up. Next slide, please. Chlamydia, more stable-ish, but certainly, still relatively high. And there's that syphilis, and well, it's all concerning. It's going up, up, up. But this bottom line, this orange line of this increasing number of heterosexual women being diagnosed with syphilis and therefore potentially passing on congenital syphilis is on the increase. Now I have to remind myself this one each time. So the number of notifications, that's right, the total number of notifications is going down. So that's that grey line at the top. But if we go to the next slide, we see that the late presentation ones are going up. So unfortunately, HIV is being diagnosed later and later. Oh, there we go. That's the later one. Sorry, I skipped a slide there. Sorry, Natalie. So yes, so being diagnosed in advanced stage going up. Sorry. So again, I've tried to define the problem, and I'm going to hand back to Natalie to tell us how to fix it.
Well, short of banning Tinder, not going to happen. We'll just try and have to manage as best we can. So It is not a values judgment. We are screening because we want our patients to remain healthy. We want them to feel encouraged and supported to come in and be screened for STIs. So let's make it a positive experience with negative results. Who are we screening? Anyone who asks. Why are we going to question them if they're saying that they want an STI check, basically? Particularly if you're a new practitioner, you know, if they are doing behaviours that are outside the heteronormative space, they might not feel comfortable disclosing exactly what's happening for them, but they know that they need an STI check. Do one. Opportunistically looking at people under 30 who are sexually active, ideally we'd be doing one every 12 months, and certainly individuals at increased risk. Now, who's that? Well, Health Pathways. They have a wonderful little rundown of who is at an increased risk. It does go through sexual history taking as well, which is really important, and I'll cover that a little bit more in detail in a minute. But your asymptomatic patients who are at a higher risk. So people under 30, I'm over 30, but it's still a cesspit. People who identify as Aboriginal or Torres Strait Islander statistically have higher rates of sexually transmitted infections. Sexually active men who have sex with men, remembering this is not just men who identify as gay men, it is a wide spectrum of behaviours. Sex industry workers, I will cover off in this a little bit as well, but discussing their sexual screening needs too. Adults who have been sexually assaulted, obviously really important, small part of that overall process of caring for these people. People who are injecting IV drugs, newly arrived refugees and migrants. So we know particularly in terms of syphilis and HIV, we can see rates at double the Australian rate of those two diseases in people from overseas. People who have had in contact with people who have been diagnosed with an STI. So that goes without saying. And pregnant women, not so much because they're at an increased risk of getting an STI, more so because the implications of them having an undiagnosed STI can be really problematic, if not catastrophic. So now that we know who we're testing, what are we testing for? So recommendation is that bloodborne virus screening is done with every STI screen on every individual. Again, not because we think they're at an increased risk, but the implications of an undiagnosed infection are problematic. Remembering that there are guidelines around the consent for HIV testing, making sure that your patients are informed before they consent to that test. Action guidelines as you go to for that one. If we're unsure of their immunisation or vaccination status, then consider doing serology for hepatitis B. Remembering you want to be doing surface antibodies, surface antigen and core antibodies if you're doing a hepatitis B screen, particularly if they're born overseas. People aged 36 and under in Australia generally will have been caught in either the adolescent or the childhood immunisation program. If they're not sure, do the serology. Considering Hep C serology in the following groups, remembering Hep C is more blood transmission, more so than sexual fluids, but these are your high risk groups. So people living with HIV or on PrEP, obviously anal receptive intercourse is linked with a higher rates of transmission of Hep C. They've had a history of injecting drug use. If they've had any tattoos, piercings, scarification, whatever the youth are into today, that's either been done overseas or in a non-professional setting. Recipients of organs or blood products that happened prior to 1990 before routine screening of blood products for bloodborne viruses was conducted. If they've had a history of incarceration, or if their sexual partner has hepatitis C infection and they're engaging in anal intercourse behaviours with them. So that's your bloodborne virus screening. So looking at swab what, where. So chlamydia, gonorrhea, urine or vaginal swab, standard. A vaginal swab is more sensitive than a first pass urine and it can be done as a self-collect. So if you have a sexually active person, if you ask them to do a vaginal swab, generally speaking, most women are going to be okay with that if you explain that it's a more sensitive test. If you're doing a cervical screening test, you can replace a vaginal swab with an endocervical sample as well. Now, pharyngeal and anal rectal swabs, this really comes linked back into your history taking and taking a really good non-judgmental history. Generally speaking, it's recommended for men who have sex with men who are engaging in behaviours which may mean there's an infection present at those sites. generally it's not recommended for women unless they're at an increased risk. So the big two that we always think about are people who are doing sex work, or if they're a known sexual contact of someone who's had gonorrhea or chlamydia, but also remembering female sexual partners whose male partners might be having sex with other men. I work in Brunswick. Ethically non-monogamous is a thing. People who are questioning their sexuality. So it's about making sure you're getting a really good history to make sure that we're screening appropriately. So you've done your screen and it's shown up that there's a little bit of something that we need to sort out. Health pathways have all of the pathways for how we do treatment, remembering that, again, non-judgmentally talking about how we can prevent a recurrence of infection, asking them about contact tracing. Do they feel that that is something that they can do themselves? Whether that's, text message, phone call, face-to-face. If they want to use letthemknow.org.au. If it's something that they feel like they may need help with, and this may be, it was someone I met on Grindr and I only know their first name, you may want to be putting them in touch with the partner notification officers who are magicians at tracking down that sort of stuff. I don't know how they do it, but they do. Obviously, there are some STIs that we do need to notify to DHHS, which most of them you can be done online. Obviously, jump on their website. If it needs to be done over the phone, the website will let you know. Also remembering we need to be doing that test of cure or follow-up, and the guidelines on who you're testing for cure when is there. And then obviously, because they've tested positive for an STI, they're then being flagged that would be wanting to doing repeat screening at least in the next 12 months under that higher risk individual protocol. So back to our who are we asking? Ding, presentations. Populations at increased risk for obvious reasons. Young people who are sexually active, age 15 to 29. Now, something that is worth mentioning around the adolescent space. So you need to be clear with your language in terms of, have you ever been sexually active, particularly for those younger adolescents who may not be consistently active dependent on partner. We want to catch people that may have had sexual relations with someone else who are not currently. So watching your language around that space. People planning pregnancy, obvious reasons. If they're coming in to discuss contraception or for a repeat script of the pill, we need to be saying, look, are we due for an STI checkup while you're here? People who are born in endemic countries, particularly where we don't know their serological status, let's think about that bloodborne virus screening. And anyone who's been overseas recently who, as I phrase, has sampled the local culture, touching base with them, do we need to do an STI screen? Was there any exposure while you were overseas? Again, if you want to become really targeted, you can jump on PenCat, and there's a whole suite of reports that will review your screening rates for STIs and bloodborne viruses. So that's always there if you need it. In terms of resources, so Vital, which is run out through the Northwest Melbourne PHN, have really great education on bloodborne virus and sexually transmitted infections. At the moment, they've recently released some videos specifically for people working in general practice on congenital syphilis, gonorrhea, chlamydia, and mycoplasma genitalium. So well worth watching, really good practical advice. They also do a large amount of CPD courses that have RACGP points attached, and they run our S100 Hep B prescriber courses in our area as well. So they are wonderful and their website is excellent. Obviously, Health Pathways covers all of the things you could possibly want to know about anything to do with sexual related infections. So they're really good if you're not sure where you're starting or it's been a little while since you've seen that presentation. Other resources that I use, so ASHM have great STI testing and management guidelines. They also have a really good policy around HIV and hepatitis testing that goes through not only the practicalities, but about how we can conduct this as clinicians to not inadvertently put barriers to testing, particularly in trans and gender diverse communities who already have barriers to testing. We really want to try and reduce that as much as possible. Melbourne Sexual Health Centre, obviously they also have really quick reference treatment guidelines too. If you're a little bit stuck, they have a really wonderful doctors only advice line. They're open 8:30 till 5 Monday to Friday, and you can give that a call and have a chat with a sexual health clinician for advice. Also worth mentioning that sexual health services and treatment are available to anyone, regardless of Medicare status, free of charge. at Melbourne Sexual Health Centre. So if potentially you have overseas students or people who aren't eligible for Medicare, that may be a treatment option that's going to make it more accessible for them. Worth mentioning, the PHN did some really great work organising some liaising between Melbourne Sexual Health Centre and 2 GP clinics in our catchment area. So Kings Park Medical Centre in Hillside and Tarneet Family Medical and Dental. So the GPs at those clinics have done further training with Melbourne Sexual Health Centre, and they'll provide bulk billed STI screening and treatment services for Medicare card holders. So that's certainly an option if potentially treatment is an expensive and cost is a barrier for treatment. Now, I wanted to do a little quick review of sex work. So it was decriminalised in Victoria in February this year, and the initial stages have been rolled out as of the 10th of May. So where that impacts on us as clinicians, sex workers are no longer required by law to have an STI screen every 3 months, and they are now in charge of their own STI screening needs. So they can choose whether or not they would like to use condoms while they're providing their services. And it's no longer a criminal offence for them to continue working if they have a sexually transmitted infection, or for their employer to allow them to work knowing that they have a sexually transmitted infection if they're working in a licensed sex premises. Now, the thing to remember is sex workers have a really long history of fantastic peer education around sexually transmitted infections, and they actually have STI rates that consistently lower than the general population. So this is not about letting it be a free-for-all and letting the STIs run free. What this is about is recognising that it is part of their workplace and health and safety that we need to take into consideration their sexual screening needs, but it is up to the individual to make that call about what is an appropriate time frame and what their screening needs are. So, like anyone who's sexually active, they should be encouraged to seek testing and treatment at an interval that is appropriate. The requirement to do so has been removed from legislation. So we're moving more from a government crime act controlled through to it's an occupational health and safety issue. And this is the framework that sex workers run in New Zealand, and it works, which is wonderful. In terms of if you have patients who are doing sex work who wanted some education, particularly if their primary language is a language other than English, these resources are sex worker focused and peer run. So Vixen and the Scarlet Alliance are sex worker associations, have really great fact sheets in languages other than English on sexually transmitted infections. Resourcing Health and Education, or RED, is a health service that's run by Star Community Health down in Port Melbourne. So they provide a health service. They also do a lot of advocacy, support service, and a pathways program for people who would like to move out of the sex work industry. So they're really fantastic resources for you to share. All right, here we go, the deep dive back into talking about what we do every day, mental health. So I'm going to pass you over to Jeannie, GP extraordinaire, to tell us all the things that we already know.
Thank you. Pop on to the next slide, thank you. So there's some stuff here that is not going to surprise any of us on this call. The mental health of Australians deteriorated as a result of the COVID-19 pandemic. There was, and this was from the a think tank report, increased levels of depression and anxiety. I'm sure there were increased other things as well, and higher levels of contacting, engaging with suicide prevention services and other mental health support services. And like a kind of, you know, a recurring theme, there's a disproportionate burden of poor mental health in certain groups. Young people, women, people living with disabilities or who already have mental health issues, CALD communities, Indigenous communities, socioeconomic deprivation, people who experience job loss, which was, of course, a huge problem during the pandemic, and people living in poor or substandard housing. And the government interventions, how come this cat only comes back when I'm talking? The government interventions had a mixed impact. So there was obviously some really good things, the JobKeeper, the coronavirus supplement, the implementation of telehealth, and the increased number of visits available under a mental health plan. But some of the more difficult things have really just been that increased demand on what is already an overburdened system, which further entrenched barriers to access. And again, in some ways not a surprise, social disconnection has a significant impact on mental health. And so that, you know, the COVID lockdowns and the subsequent mental health problems that came with that have reinforced that evidence of the link between isolation, loneliness, and poor mental health outcomes. Why this matters, I mean, obviously, you know, increasing rates of mental health issues clearly matter, but specifically the increase in people needing their supportive mental health services is increasing. However, the ability of services to keep up just hasn't increased at the same pace. Specifically for us here in Northwest Melbourne PHN, we've got a rapidly increasing population of young people, double the rate of the rest of Victoria. And those rates of mental illness were already increasing prior to the pandemic. Nearly a half of our catchment were born overseas. And we also have higher rates of people with poor English language proficiency. And unsurprisingly, called groups are more likely to encounter difficulty, less likely to engage with mental health services. Our PHN catchment has areas with higher refugee and asylum seeker populations who have their own mental health challenges. And there's lower health seeking behaviours in low socioeconomic areas. And of course, the service availability and affordability is often a barrier in those areas as well. This is just a little refresher. This is from 2014. This is a little refresher about the spectrum of mental ill health at any one time. So at any one time, and this again, this is pre-pandemic, at any one time, out of Australia's population, which off the top of my head, I think is it 25 million? I think it's 25. So 3 million people at any one time are already suffering from mild to moderate mental unwellness. And over 500,000 people at any one time are experiencing severe either episodic or persistent mental unwellness. And 65,000 people at any one time are experiencing very severe, complex, multi-agency mental health needs. Next slide. And this is a little, and this is from the PHN stepped care model, that really the idea is for the services to match that degree of unwellness. So, you know, the mild mental illness having less resources than the moderate mental illness, which has less resources again than the severe mental illness. So that's that, trying to match up where resources go based on where those numbers sit. So again, I'll hand over to Super Natalie to talk to us about what next.
I probably should not have labelled this slide, how do we move forward? It should just be how we endure, but we will maintain a positive mindset. So how do we move forward? Okay. We all know that the system is close to, if not already broken. The system of better health or better mental health access, you know, under mental health care plan, refer to psychologist or mental health social worker. It doesn't work. We can't do that for everyone now because the system, it's not there. There's really limited availability and there's long wait lists. I know Jeannie and I have spoken, and it's not uncommon for you to have a 3 to 6 month wait list for people to try and engage with a psychologist. I think the thing too is we have a population that is really well versed about what they can get under Medicare, which is, that in itself is fabulous. People know to come in and say, I think I need a mental health care plan. My mental health is struggling. What we need to do as clinicians is reframe that, not because we're denying access to that service, but explaining, okay, well, I'm so pleased you've come to tell me, let's have a chat about what's happening mental health for you at the moment, and let's find the right fit for what's going to help you get back on track and give you that wellness. God, I hate that word, but that wellness back for yourself. There are things that we need to take into consideration. So affordability, can our patients afford to pay for a service? Location, access, language, it's all really big things that we need to take in, and that differs from person to person. Now, the PHN's got a really fantastic patient guide called Looking After Your Mental Health and Wellbeing that's available on the website, and that's available in 6 of our common languages in our catchment area. It's Wonderful. In terms of, particularly for people that maybe haven't ever engaged with mental health services before, it gives a really good rundown and also provides some framework about where they fit in the grand scheme of people experiencing mental unhealth. So I do recommend having that available. It's really good, and not in a go away and read this and come back, but look, this is something, and it has some things in there you might find useful as part of that pack you're giving to your patients while you're arranging support services. So in terms of, for us, we need a service. Where do I find it? You jump on the PHN website and go to System of Care Services. I've popped the website there for you to have a look at. And this is the directory of stuff that's available within the PHN. So not just PHN run services, but also services that are run by other providers. The directory will go through what they do, how you access the service, the referral details, what they offer. It's presented according to age group, the target population, the location, and the level of vulnerability, so where it fits in terms of who they're really targeting in terms of patient need. So let's have a look. So let's start at the really big end of our spectrum of people who are well. We want them to stay well. We know that there's threatening factors to disrail people's mental health, particularly post-pandemic. Price of petrol, price of gas, job instability, being a young person sucks, we've all got gonorrhea, all of those things. How do we maintain that wellness? So we want to promote physical health. So obviously the big things, eat well, exercise, all the stuff we know we should be doing, but you know, it's questionable. Making sure they're getting good sleep, so reviewing their sleep hygiene. We know people who are sleeping poorly, that has a really significant, a really quick impact on mental health. Managing stress, increasing connectedness with others, participating in meaningful activity. So it's really looking at that whole person's, not just their physical health, that mental, social, emotional well-being, and making sure they're supported. And there are services available. Have a look at your community health centre. They all run, you know, engagement programs for all across ages of the spectrum. They run exercise programs. Looking after little things that might be niggling now saves us having to do 20 referrals to a psychologist later if we get it right. So resources that you can refer your patients to in the interim. So Head to Health. Now, I'm going to delineate. This is the national website. I'll cover this in a minute. It's a consumer-directed website. It covers mental wellness, education. It has digital health resources. It refers to apps that are well-researched and well-recommended. Beyond Blue also has a section called Personal Best, and it's really more around that wellness and maintaining mental health focus. They also have a section that's specific to COVID-19 and emerging from the COVID-19 pandemic that's well worth a look at. Your community health services, so you'll know which one you're in the catchment area for. Jump on their website, have a look at their health promotion activities. There will be stuff there that's really useful for your patients. Now, at-risk groups. So this is people that maybe we've had a little bit of a wobble. We're not really at the, oh, no, my mental health issue is coming back, diagnosable illness. It's that gap in between where we need to get some really quick support happening to get them back on their way to wellness. So this is when we're seeing those really early symptoms, or they have a history of previous mental illness and we're sort of in that watching mode and making sure that things are going okay for them. The evidence shows that there is more benefit in sort of peer or group support or those sort of low-level interventions rather than that one-on-one psychology. It's not saying that that doesn't have a part. It's just saying that we can put those lower-level, lower-cost intensive services in at this point, and for most people that will be very effective. So obviously encouraging them to talk with friends and family. Who are their support people? You know, who are the 5 people that you can rely on and talk to about things? Peer support groups. Beyond Blue has a number of online forums. Face-to-face groups are available as well. Again, go through your community resources, go through Beyond Blue, there's a directory there. Counselling, again, whether that's community health centre, whether it's phone-based, have a chat with them. Does their employer offer an employee assistance program? Letting your patients know it doesn't have to be work-related stuff. That can be used just for general life stuff. Good quality apps, so things like Mood Gym, Smiling Mind, eCouch, MindSpot, they're all really good, well-researched, well-resourced applications that your tech-savvy patients can use, and potentially for your millennials may actually enjoy, because it's not as confronting as having to go and talk with a whole bunch of people that they don't know. Moving down that spectrum, so we're now looking at that mild to moderate mental illness. And this is really when we're stepping in with that mental health care plan. This is when that sort of one-on-one support really starts to get people back on track with things. It doesn't mean that we negate the use of the strategies we were using before, so those peer support groups, the counselling, the apps. It just means that potentially that's not going to be quite enough, and they do need that one-on-one therapy to really help them get back where we want them to be. So mental health pathways, if you're a little bit sort of, oh, where do I start? This is really complex. This is where you start. You come to mental health pathways, and this steps you through in our region, how do we access resources, what resources are there, what available for that particular concern for our patient. Now, head to health. Now, we used to call this head to health. So you remember the cute little bear that is actually tattooed on my body? This is what that's called now. So this is the Victorian setting. I don't know why they called it the same thing as the national setting. They said it was bringing into line. It's actually two separate services. What this is a centralised triage and intake service. So it's what we call a no wrong door approach. It doesn't matter at what stage a consumer is coming and accessing this service, they will be pointed in the right direction. It's not, well, you know, this is too hard for us, you need to call these people. They will be triaged. They will have a question about how they're feeling, where they're at with things. They'll then do a little bit of large counselling over the phone, and then talk about what services might be appropriate and arrange triage and arrange entry into those services. We can also refer to this service for our patients, but consumers and family members can self-refer for this as well. So in response to the coronavirus pandemic, there has also been mental health and wellbeing hubs that have been set up. And again, this is telephone or face-to-face support. Does a little bit of the mental health stuff, but also will cover alcohol and drug issues, issues around finances, practical supports, and it can help link consumers with appropriate services that are available. So again, patients can self-refer over the phone. They are in specific locations, often within other services. So if you jump on the website there, you can look at which ones are available, which ones do walk-ins, and what days they're open. So that's another option that's available for your patients. Helplines, really good stopgap for that patient that has an appointment at 10 to 6 on a Friday night of, I'm feeling really down, I think I need a mental health care plan, I'm really struggling. They're not at the point where we need to refer them to a CAT team, but they need to talk to someone, and we've got 7 minutes to put in. These are your services. So Lifeline's obviously the big one. Their annual report was heartbreaking in terms of the increase in services that they provided during the pandemic, and it's not slowing down. That's because they're really good at what they do. They're fabulous. Men's Lines, specific for men who we know are maybe not so great as engaging with mental health support when they need it. So Beyond Blue is also an option as well. Now, all of these services, phone is their traditional mode, but they also have either a text service, a web chat option, or a video chat option. Worth mentioning for Men's Line, they also have an Arabic language callback service. So men who would prefer to speak to someone in Arabic can actually call up and be asked to put on the list, and they'll have someone call them back. Through VARS, the Victorian Aboriginal Health Service in Preston, Collingwood, around that area, they have a phone-based counselling and support service called Yarning Safe and Strong that's available to people who identify as Aboriginal or Torres Strait Islander. Care in Mind also have a wellbeing support service. So it's a 24/7 online, so web chat or phone-based counselling service for people who feel like they're struggling with their mental health, but they don't fit a DSM diagnosis criteria. So that's another good option, particularly if they're finding that getting through to Lifeline is challenging. This is something that's available in our area as well. Specialist services that are in our catchment area. So we touched on earlier that people who have come as a refugee or asylum seeker may have experienced trauma, violence. They have additional needs that are specific to their situation. So there are services out there designed to support these groups. Foundation House, so they do individual counselling, they also do family counselling, they have group programs, they also offer some practical supports as well, and they've got centres in Brunswick, Dallas and Sunshine. And that's for people, really specifically refugees who've experienced torture or other traumatic events. The Asylum Seeker Resource Centre, they also have a counselling service as well, based in Footscray. So the telephone triage is state-based, but the actual counselling service is provided through Footscray. It is also worth mentioning that they'll actually need to sign up as a member of the Asylum Seeker Resource Centre in order to be able to access that counselling support. Obviously, they offer a whole bunch of financial and material supports as well, though, so well worth it. In Brunswick, we have the Cabrini Outreach Asylum Seeker and Refugee Health Hub. So it's a bulk billed or free mental health and nurse-led primary care service. So if your patient have Medicare, they will be asked to provide their Medicare details. If they don't, they can still access that service at no cost anyway. There's also the sexual assault crisis line. So sort of linked with what we used to know as CASA and CASA House. It's a free call service that's available after hours, 24 hours over weekends and public holidays. And it's crisis, so that immediate, within 2 weeks post assault or historical, they can ring up and access that sort of short, sharp counselling. If it is a recent sexual assault, it's also the triage point that triggers the crisis response. They can have people come out. So if you've got someone who's really traumatic, it's a recent resource, they can actually arrange someone to come out and meet them in a place and have that one-on-one face-to-face support in that immediate aftermath time. So looking more now towards resources that are available for people in that initial stages, so mild, moderate illness, we're going, yep, there's some, anxiety or depression disorder definitely happening here. What we used to call ATAPs, we now call the Care in Mind Targeted Psychological Support, or the TPS. So this is up to, depending on patient need, 12 sessions of counselling support with no out-of-pocket cost to the patient. Now, obviously, we would refer everyone to this if we could, so there are some eligibility criteria. They need to have a diagnosed mental illness. So you're going to need to do a mental health care plan in order for them to access this service. Or if they're under 18, a provisional diagnosis. Generally speaking, we're reserving this service for people who may not be able to afford fee-based services, particularly for those in priority population groups as listed there. So groups where we know that potentially there are barriers to them accessing a traditional service. There's a Care in Mind referral form, which I'm sure you're all well acquainted with. Severe mental illness. So this is when the horse is really bolted and we're struggling. Our patient has significant needs. Often at this point, it's not just the actual diagnosed mental illness, it's all the other stuff that goes on around it. So what we're looking here is multidisciplinary, long-term care to support that person, get them well, prevent escalation, prevent recurrence, and aid their recovery by having someone support them through that process. NDIS might be helpful. I think we all know what a fun time it is applying for the NDIS with really obvious physical disabilities. It's more challenging for people with mental health issues who are eligible, but honestly, the capacity to deal with your own severe mental health issues and try and access the NDIS, that's problematic. So it's not usually my first point of call for accessing services. It's something we put on the back burner for when we've recovered. Let's now get that into place because we know it potentially might flare up in the future. Obviously, if there's issues with alcohol or other drugs, then a dual diagnosis service is going to be appropriate for these people. So under Care in Mind, there's a couple of services. So the first is IS, or the Intensive Support Service. Now, worth flagging, these are not crisis services. These are for your patients that you're very concerned about, but they are not at immediate risk of harm to themselves or others. What this is a program delivered by mental health nurses as really care coordination for people with severe mental illness who also have other primary care needs that need help with as well. So it's about having someone in their corner to help them navigate life until they're back on track and getting those frameworks in place to prevent relapse. It's done in a multidisciplinary approach, so they will be liaising with the patient's GP, their mental health support team as well, and the referral for that goes through the Care in Mind referral form as well. Again, it's a great service. We wish we could refer everyone, but that's why there's eligibility criteria, which I've just listed here. I won't go through them. You can have a read when you get the slides, but well worth looking into. Fabulous service for patients that need it. Now, the suicide prevention or post-vention support service, again, this is not a crisis service. This is not a replacement for the CAT team. What this is for people that are maybe having thoughts of self-harm or suicide, have recognised that they have protective factors, but really need a support service to avoid them getting to the point where we need to be referring them on to an acute service. So phone line, it is for people who are either at that point where they're at an elevated risk of suicide, or for friends, family members of people who have experienced the suicide of a loved one who would like some support or a little bit of counselling, or someone to listen to, for them to have a chat. That's what this is for. People can access this service even if they've had a mental health care plan in the current calendar year, or if they've accessed one of the other Care in Mind services, they can still access this service as well. Really, it's looking at those people that have been released from hospital or ED following an attempted suicide or an incident of self-harm, or those people that we're like, I'm concerned, I'm not worried that when you leave here, you're going to self-harm, but I am very worried that your mental health is in this bad a place. That's where this service fits in. Again, Care in Mind referral form. Then we have the absolutely heartbreaking thing of where our patients are at immediate risk. So your crisis services. So for the Northwest Melbourne PHN, this is our crisis services across our catchment area. Contact details are there, and I've just popped in the areas that they service. Northwest Mental Health Triage, certainly taken the lion's share of that one. Thanks, team. Now, when you ring a phone triage, they are guided by the Acute Community Health Service guidelines. So there is a set standard at which they need to follow. And generally what this service is for people where the current supports that they have in place have been overwhelmed and that person needs immediate support. So the main sort of reasons, but not exclusively the reasons these people are being referred to these services: severe acute psychological distress, first onset psychosis, acute relapse of a mental illness that was already, that the supports that are in place just aren't working. For people that are experiencing issues where alcohol or other drugs are the main problem, this is not the CAT teams. They won't take anyone on. That's a completely separate kettle of fish. This is for mental health related issues. Likewise, it's not for people who have that sort of mild to moderate depression, anxiety, or adjustment disorders. This is really for those really acute, need quite rapid intervention, stabilisation on medication. That's where this comes into play. So when you ring a phone triage service, you'll be asked who the call's about, some basic demographics. Does the person know that you're contacting the service, and what's happening for them? What sort of history is going on in the past? Who else is involved in their care? Who are their supports? And any other issues the other person may be experiencing. So in terms of housing, safety, are there alcohol issues? Is there abuse issues? All those sorts of things. It's about trying to give them a complete picture so that they can make an accurate assessment about what the best care for this person is going to be. So the outcomes of a call to triage. So if it's severe enough, they'll go, okay, let's bring them into an emergency department. We'll get our mental health teams in there to touch base with them. If they're not at the point where they need crisis right then, right there, ED treatment, there may be another program that is run by that mental health service that may be appropriate, in which case they will arrange referral and intake through them. If specialist mental health services aren't the most appropriate option, often they will have a chat with you about what other things you could consider for that patient. Say, do you know this is in your area? That might be a good fit. Obviously, this is when the service is working and not overwhelmed and they're as stressed as we are. So I think as healthcare providers, we all need to remember we need to be kind to each other. We are all struggling. It is not a fun time to be in any area of the healthcare system, and that includes our triage staff. If you are lucky enough that your patient has private health insurance, there are options that are available for same-day admission in the private sector. Worth mentioning, these are for voluntary admissions only, so the patient must consent to being admitted and they can't have other stuff going on medically. So in terms of substance abuse issues, alcohol issues, or medically if something else is happening, then this is not an appropriate option. But if it is mental health related, they need to be an inpatient, they have private health insurance, these are options that are available. It is worth mentioning that the Melbourne clinic is the only one that will accept a dual diagnosis or has a dual diagnosis service out of all of these options, but they're there and we can use them. So just as a brief summary, if that was really just too much mental health stuff when you've been thinking about it all day, the things you really want to be knuckling down is, so where is your patient at with their mental health? Where on that spectrum are they sitting? What is the evidence for the level of support that they need, and what do you think they need? Not your patient comes in and wants a mental health care plan. Let's help manage their expectations about accessibility, affordability, and what's actually available, because often they don't know what else is available. They just know they need to have help, and that's how they know help exists. So let's teach them about the other options for help that are available. What pre-existing supports are available? Let's identify within themselves the resources that they have to help themselves. Is there supportive family? Do they have private health insurance? What other things are accessible to them? And what are the barriers for your patient to accessing care? So obviously, if language other than English, we're going to refer people to Ringing Lifeline through the TIS number, all those sorts of things. So there are resources available. Let's make sure that we're getting those resources to our patients. Now, you've been such good listeners for the entire of that entire presentation, so round of applause. Do you have any questions? Is there anything you'd like to know or wanted more information on? Please enter the chat.
Thank you very much, Natalie and Dr. Jeannie. I have one question that's come through the Q&A box. So it's regarding sex workers, and the question is, why is it legal for a sex worker to continue to offer services if they are positive to STIs?
So I think it's not so much that the sex worker is going to go and do that. It's just the fact that it's no longer a criminal offence. So it would be no different to someone having a chlamydia diagnosis that has had their 2 doses of azithromycin and then hitting Tinder on a Friday night. So obviously, most sex workers probably wouldn't go and work with an STI. They would wait out their treatment. But remember, we're talking about people's livelihoods. So if they have been treated with STI and they make a risk assessment that, you know what, I'm not going to be providing intercourse services, I'll be providing oral services only, they can now no longer be criminally charged with providing that service.
Sorry, Natalie, I was going to just support you in that. I think it's about moving it from a criminal thing to being part of healthcare. You know, there's lots of workers who have lots of health issues that need help with their health issues as part of their work, and it doesn't make it a criminal offence. So, and as you said during your talk, it's also about this is about them looking after themselves as workers rather than being a crime. Cool. Any other questions?
And I think that by moving it away, by legalizing it, I think that some of those issues may be addressed more openly than through backstreet doctors or backstreet alleyway treatments. I think they may come out in the open and be treated properly than through, other illegal means.
That's right. It's a health issue, not a criminal issue.
Yeah, as we have seen in some countries with legalizing of, other similar issues. So yeah,
I mean, it's not a crime to go to work with a cold at the moment. It's really stupid, and but it's not a crime. It's the same issue. It's about looking after people's health, not criminalising someone's workplace when other workplaces aren't criminalised. Sorry, Natalie, you were going to say something.
I was just going to say, remembering just on the topic of the decriminalisation, so this is only the first raft of changes. So the second raft of changes that will come in later this year, mid next year, pardon my French, are looking around removing the requirement for licensing, removing the requirement for where people who engage in sex work can work as well. So I'd certainly say go and have a look. It's amazing, people engaged in sex work have been lobbying for these changes for a really long time. And I think it moves it away from now you're not going to have the police involved, you're going to have work safe inspectors involved. I think that's sort of the mind shift.
Yeah, it's a workplace, so it gets treated like a workplace. Yeah.
Yes, absolutely. And that's a much better, safer way for people to do sex work than what we've had up until now.
Natalie, you might know this better than me, but my understanding when they, as you say, they followed the New Zealand model, which was passed before I moved here, so back in the early 2000s. And my understanding is that it revolutionised safe access, safe workplace. There were much less of all of the issues.
Yeah, absolutely. I mean, I think the one big thing that really taken away, sexual assault on sex workers dropped significantly because they now can go and report, how receptive the police force is to these sorts of things. That goes beyond the point. But from a legislative perspective, it's giving sex workers more agency over their rights to protect themselves. And that's incredible. That's amazing. And, there's lots of issues outside of that, which unfortunately are part of dealing with humans, but it's moving towards a much safer option. And that's what we want for people. We want people to be safe at work, regardless of what work they're doing.
Exactly. Our presentation was so good, Natalie, that there's no questions.
That's good.
I think it was a very comprehensive presentation. Thank you very much. We might wait for another couple of minutes to see if there's any other questions coming up. And Dr. Jeannie, and Nat, for you, I just have a question as well. Now that we are in the thick of the middle of winter with flu and COVID again returning, do you see any return to normal primary care settings or primary healthcare settings, or are you still sort of putting fires out?
I think the first thing to say is we're never going back to what we used to do. It's a new normal. So business as usual will never, but business as usual will never look like what it used to look like. So I think that's the first thing, and that's not necessarily a bad thing. I mean, when I think about the fact that we had people with influenza sitting in a waiting room, coughing and sneezing next to the person next to them who's a pregnant mum coming for an antenatal check, and a healthy baby having a vaccine, and someone with a sprained ankle, I just kind of shiver. So some of the stuff that will never go back to how it was is a good thing. So with that aside, that business as usual will never be the same. I don't know where to start. No, basically, the outside world think the pandemic's over, but all of us in healthcare know that it's most certainly isn't. And, we've got the deferred care stuff. We've got ongoing COVID illness. We've now got the new thing where we can prescribe anti-COVID virals, which is amazing, but also a workload. And just, the pressure on appointment. We've started offering some face-to-face non-COVID respiratory appointments, and the pressure on those appointments is immense. So that's my thoughts on it. Natalie, I'm sure you've got a different view.
Probably not different. I feel like that's too strong a word. So I also sit on the General Practice Expert Advisory Group as part of the PHN, which if my tenure and the tenure of some of the other staff is coming up to an end. So if it sounds like something you'd be interested in doing, please get in touch with the PHN and put an interest in, because I'm ready to hand over the torch. So certainly we've been discussing in meetings that we're all struggling, and I feel that probably doesn't come as a surprise to everyone. We've been dealing with post-COVID, managing patient expectations, managing a reduced workload, now with increasing respiratory illness, because we also know it's not just COVID, it's now influenza's having a bumper season, respiratory syncytial virus is having a bumper season, gastro, hand, foot and mouth. I think everything that we would usually see in day-to-day practice that's sort of had a bit of a hibernation over the last 2 years because of social distancing and lockdowns has really come back with a vengeance. So the demands have gone above and beyond what we would normally see, but also then with the restrictions of reduced workload, reduced availability, increased PPE requirements. So as Jeannie said, we're never going to go back to situation normal. I think particularly during the election, the media around COVID numbers really dropped off. I think, you know, we all I still remember walking into work the day that Victoria hit 957 cases, and all of us were just walking in and our hearts had sunk, and we're like, where do we go? And that was prior to the immunisations. We're now hitting 9,000-10,000 cases a day, and it's not even newsworthy. So I think there is, I don't know. I think we're all just so tired and managing as best we can. And I'm hoping the viruses just go away.
Yeah, and look, I think on that, Natalie, that you know, certainly our reception staff are getting more arsey, inappropriate behaviour now than they have the whole time. Yeah. Because again, apparently out there in the big wide world, the pandemic's over. And so why do you want me to wear a mask? I don't understand why you want me to wear a mask. Why do you want me to wait outside for a respiratory appointment? That's outrageous. And so at a time when, as you say, and I'm sure everyone on the call's got the same thing, we're all knackered, we're all burnt out, we're having staff furlough every 5 minutes, demand is high, patient misbehaviour is high. I think 2022 has been harder to work in than any of the other two, personally. And I guess that's partly our own personal hope that it might be over, because, you know, all of us are also living through this pandemic. Which I think we have to remind ourselves sometimes to, you know, in terms of our own self-care, is that we too are living through this and having to, and we also all went through lockdown and etc. Anyway, I hope that answers your question, Sadia.
Unfortunately, yes, it does. And I get a feeling that, for the lack of a better word, I almost feel that, you know, with the patients having gone through 2 years of COVID and now them wanting for some form of normality and seeing some form of normality return, they feel that they you know, they shouldn't have to have the restrictions that were applied during COVID, whereas those restrictions certainly do need to be applied to prevent a return or to prevent a blow up of, you know, what is just being contained on the surface at the moment. And conveying that is quite a challenge to everyone, and especially people who are not in healthcare, and especially in people who didn't believe in COVID from the beginning, and, you know, who didn't believe in vaccination, and it was quite difficult to convince them. So there is COVID fatigue and just in general. So I don't envy you your jobs, and yeah, best of luck to everyone who's working in healthcare at the moment. I'll just quickly point out to everyone, please, my colleague Olivia, who's providing back-end support, she's put an evaluation survey in the chat. If I can please request everyone to complete that, as we really value your feedback. And if there's nothing, no more questions coming in for the speaker panel, then we're happy to end the webinar for tonight. Once it is recorded and ready to upload, we'll put it on our website and send you a link to it. And for all further education sessions coming up, please continue to refer to our website. So a final call for any questions.
I think worth mentioning, the next session will be on the 19th of July at the same time, and that's looking at middle age, or, you know, people of a certain age, and that will be looking into cardiovascular disease, diabetes and cancer screening. So pop that in your calendar, because we'll be back at it again.
Yes, the second session of the Deferred Care series. So we look forward to seeing you all on 19 July. Excellent. Thank you very much, everyone. And once again, a big round of applause. And thank you very much to Dr. Jeannie and awesome Natalie for presenting tonight. Thank you.
Thank you, Natalie. You're amazing.
Right back at you.
Bye-bye. Thank you.
Thanks, everyone.
Thank you. Bye.